So today we'll be talking about the antiarrhythmic medications. It was really confusing when we talk about. Can you close the door? Yeah. It was confusing, not confusing, actually complicating when we talk about the atrial fibrillation, um, because when it comes to antiarrhythmic medication, they really need certain lecture for them. The main anti-arrhythmic medication classification we use is the Vaughan Williams classification, which is really old, kind of 70s. Um, and actually, it's very practical. This is what we use, and this is what you need to pay attention to. I'm going to go over it quickly, and I'm going to give you at the end information of what you need to do for your day-to-day work in cardiology and electrophysiology at large. The class one is the sodium channel blockers, right? And the sodium channel blockers, these medications, they tend not to prolong QT interval. Okay, so keep that in your mind. I will talk about exceptions. The first one is class 1A, which is the procainamide, quinidine, and disopyramide, procainamide, quinidine, disopyramide, and the class 1B, which is lidocaine and mexeltin, which is the kind of the PO form of lidocaine, and the class, and phenytoin as well, which we don't never used it as antiarrhythmic medication. And the class 1C, which are the one that we use a lot, which is propafenone and flecainide. The class 2 medications are the beta blockers. Class 3 are potassium channel blockers. This medication prolong QT interval, and you have to be aware of that. And then you have the class 4, which is the non-dehydropyridine calcium channel blockers, and then the class 5, kind of miscellaneous, which is digoxin and adenosine. Few words I want to tell you that beta blockers and calcium channel blockers, they do not really help arrhythmia in terms of converting somebody in AFib, flutter, or ventricular tachycardia to normal sinus rhythm. So if you hear that, patient will start on cardizem, converted to sinus rhythm, or give patient digoxin, converted to sinus, this medication do not help in terms of rhythm control. They can help with rate control, and don't be confused about that. If you go back to the classification, the class 1A sodium channel blockers and the quinidine, procainamide, disopyramide, we don't really hardly use them anymore. Procainamide, we use it sometimes if you have accessory pathway with atrial fibrillation. You don't want to give calcium channel blockers or beta blockers because you block conduction via the AV node, and then you activate conduction via the accessory pathway. And in that case, if you're in AFib, you're going to go back, become VFib, and you have arrest. So this is why we use something like procainamide or flecainide, sodium channel blockers, in this case, procainamide IV, to help blocking conduction in these patients. And, most of the time, this is ER medication and rarely used. Procainamide also been used it multiple times if you have somebody with VF storm or VT storm. You use amiodarone, then you use lidocaine, and you really ran out of option. The third antiarrhythmic medication you can use is procainamide IV. Quinidine has been used in different places, such as Brugada syndrome, to help, but we don't really rarely use it here in America for any kind of rhythm control anymore. It was used for atrial fibrillation at some point, but we don't really use it. And disopyramide, we use it in case of HOCM and somebody with atrial fibrillation, because it has some kind of chronotropic and inotropic negative effects, and this is what you need for HOCM patients. So procainamide sometimes, disopyramide, HOCM, quinidine, we don't rarely use it, and that's class 1A medications. Class 1B, lidocaine and and Mexiltin. So these medications, they have kind of effects on ischemic heart, and they shorten QTC interval. Ischemic heart shorten QTC interval. So these medications can be helpful in the case of uh, these medications can be helpful in case of having somebody with VT. If you think that it's ischemic cardiomyopathy or patients having acute myocardial infarction. Remember something about the lidocaine is the first side effect you have is tinnitus in the ears. And then if you use it beyond 48 to 72 hours, you're going to start having, confusion and altered mental status. So be careful. Don't ever use it beyond 48 to 72 hours, especially if you have kidney dysfunction. Then the Mexeltin, you can use it PO, and you use it PO as second-line agent in case of amiodarone is not effective or toxicity to amiodarone. If you're going to use it, probably, you have to think about VTVF ablation. And all these medications, the lidocaine and Mexiltin, they don't have any effects on the atrial tissue, only ventricular tissue. So just also keep that in your mind. The class 1C, which is the flecainide, propafenone, they are commonly used. Flecainide can cause dizziness. 40% of patients, they can have dizziness with flecainide. So you can either decrease the dose to 50 twice a day or just stop the medication completely. Propafenone, it can cause metallic taste in the mouth, and it can cause actually bradycardia because it has some beta blocking effect, profound actually beta blocking effect. So if you're bradycardic a little bit, or your patient is bradycardic a little bit, use flecainide, don't use propafenone. These medications, there's a black box warning. So I'm going to mention black box warning on medications because you have to be careful. That means lawsuit if you screw up. So black box warning when in case of if you have ischemic cardiomyopathy, ejection fraction is low, don't use class 1C medications. So whoever works with me in the clinic, I always ask, did this patient has CAD, history of stent, history of MI? If yes, we cannot use propafenone and flecainide. If patient has decreased ejection fraction less than 50%, we can't use these medications. And that really goes back to the CAST trial in 1992, where they found there's increased mortality if you use these medications. So we'll go back on these pearls that you have to know about each medication. Now, class 2, which is beta blockers, we're not going to talk about that. Class 3 are potassium channel blockers, which are sotalol, dofetilide, amiodarone, dronedarone. So these medications, let's talk about sotalol first. Sotalol it can actually affect the atrial tissue, sometimes ventricular tissue. Some old, old electrophysiologists, they like to use it for ventricular tachycardia. I don't really like to use it for ventricular tachycardia, but if you take a look at the guidelines, sotalol can be used in case of atrial fibrillation if your ejection fraction is normal and you have coronary artery disease. Sotalol can prolong QTC interval. If you're going to use smaller dose, 40 twice a day, you're going to have only beta blocking effect. If you're going to use higher dose, you're going to start having potassium channel blocking effect, and this is what you need to do. So small dose are not going to be effective for your patient if you're going to try to control rhythm in this patient. So in general, we like to admit patient to the hospital to start this medication. However, I've been using it sometimes where I start 40 twice a day, bring patient, get an EKG in next week, then increase it to 80 twice a day, bring patient the week after, get an EKG, monitor QTC interval. Your kidney function should be normal, and you have to adjust medication based on your GFR. So if your kidney function is elevated, you have to lower the dose or just use it once a day or every other day or something like that. But you have to be careful about the kidney function in sotalol. The dofetilide is the same. Dofetilide, you cannot use this medication at home, outside the hospital. You have to monitor your patient. You have to get an EKG before and 2 hours after each dose, and you have to have at least 5 doses of this medication. It's a GFR. If your GFR between 40 to 60, you have to lower the dose. If your GFR below 40, between 20 to 40, you have also to lower the dose, 500 to 250 twice a day, 125. So always make sure to check the GFR and adjust the dose accordingly. And then if there's any increase of QTC interval above 500, you have to adjust the dose, not to stop the medication, just adjust the dose. And whoever covers at night, sometimes you get phone calls at night from the Dophytylite patients, because the more bradycardic you're going to get, the more prolonged QT interval you're going to get. And also there's another phenomenon in these medications, which is the use dependence kind of effects, where the slower the heart rate, the more effect you're going to get from these medications, the more prolongation of QTC interval you're going to get. And this is in the case of sotalol and dophytylite, and you have to be careful not to lower the heart rate quite a bit, i.e. don't use high doses of diltiazem or metoprolol in this kind of patient to slow the heart rate slow enough to prolong the QTC interval. The other medication is amiodarone. Amiodarone has potassium channel effect, beta blocking effect, and actually sodium channel effects. Somebody actually asked me not long time ago about this. Where's Alicia, by the way? Okay. Somebody asked me the other day about the amiodarone. Amiodarone is the only medication that we can be kind of liberal in a QTC interval, because there is small, even negligible association or negligible association with the QTC interval and between the prolonged QTC interval in the case of amiodarone and torsades. It's pretty safe medication. Unless your QTC interval 600, 650 or more, do not stop the medication. It's pretty safe. Amiodarone can be used in all kinds of heart arrhythmias. The problem with amiodarone is toxicity. So it's cumulative toxicity. In other words, the more use of the medication, the longer the duration, the higher the likelihood of toxicities. Affects the eyes, thyroid, liver, and lung. If you're going to have long-term patient on amiodarone, you have to check eyes yearly, thyroid function yearly, liver function test yearly, and you have to have a baseline PFT and every year to check the DLCO. And if you have decrease in 10 to 20% DLCO, you have to stop the medication. So always remember that, and always keep that in your mind. And if you have a tiny lady on, tiny lady of 400 twice a day, or 400 once a day, of 200 twice a day, you have to be careful. You really need to cut down on the medication, and you have to justify it. So you have to have justification for using amiodarone in these kind of patients. We usually tend to use it for patients who are elderly, nursing home patients. Is very reasonable. Remember that amiodarone it has some beta blocking effect. So in case of your patient in the ICU, let's say, and the blood pressure is on the lower side, you can use digoxin, and patient continue to have issues. You can actually use amiodarone for its beta blocking effect by giving this medication for elderly patient or patient in the ICU to lower their heart rate. Because if you're going to use calcium channel blockers or beta blockers, you're going to lower blood pressure. So this medication has, especially with the PO form, does not really affect the blood pressure that much. And we can use it for rate control in that case. That's reasonable to be used, actually. Dronidarone, I don't like it very much. Dronidarone tend to be like amiodarone, but does not have these kind of thyroid / other long-term side effects. There was a trial called Athena trial. This trial, they found that dronidarone can increase heart failure exacerbation. So if you're a patient with heart failure, doesn't matter, systolic or diastolic, class 3 to 4, or recent exacerbation of congestive heart failure, or patient that you think is permanent atrial fibrillation, in that case, you cannot use this medication, and you have to be very careful. So I would not recommend to use dronidarone. There's an indication for dronidarone if you have somebody with coronary artery disease, normal ejection fraction. In that case, it's reasonable to be used. It's pretty freaking expensive as well, with its just not very significant effects. But CAD. So now, if you have a CAD, atrial fibrillation, and normal ejection fraction, you can use dronidarone and what? sotalol, right? If you have decreased ejection fraction, the only medications that you can use are what? Amiodarone? No, for rhythm control. You can use amiodarone and you can use dofetilide, right? Now, if you have somebody with decreased ejection fraction and uh, kidney failure is very, very bad, close to dialysis, or their QTC interval is very prolonged, in that case, you can use what? Amiodarone, you cannot use dofetilide. So it's kind of art of medicine. If you have somebody who's younger, um, you can use flecainide without CAD or decreased ejection fraction, you can use flecainide and propafenone, and I use these medications a lot. There's a concept called pill in the pocket approach, and these came from the fact that there's something called use dependency or reverse use dependency. If in the case of use dependent medication, which is flecainide and propafenone, the faster the heart rate, the more effects of propafenone and flecainide you're gonna get. The slower the heart rate, the more effects of sotalol and dofetilide you're gonna get. So sotalol, dofetilide, they have this reverse use dependency, and flecainide, propafenone, they have this use dependency. So the faster the heart rate, flecainide, propafenone, the faster they're gonna work. This is why they came up with the concept pill in the pocket approach. If you have a fast heart rate from atrial fibrillation, you can take 150 to 100, maybe 300 of flecainide, and that can convert you to sinus rhythm in 1 to 2 hours, maybe half an hour actually. Just this weekend, actually, physician called me, told him take 150 of flecainide, and he used to be the chairman of the chairman of the board of medicine in the state of Florida, so he reviews cases until now. He told me, oh, I read some VT. I told him, man, I saw it one time in my life, so just take the damn medication. Got text message, half an hour, he converted to sinus rhythm. Remember, with these medications, because organizing the AFib to flutter, you have to block the AV node with calcium channel blocker or beta blocker. Always remember that. And if patient doesn't want to take medication, just give them some metoprolol. Tell them to take this metoprolol with the flecainide or propafenone if you're going to use this pill in the pocket approach. The sotalol, sotalol and dofetilide, they tend to use when you're bradycardic. So if you have somebody who's faster heart rate, unlikely to be effective unless you cardiovert your patient, and that will help in identifying your QTC interval as well while your patient in sinus rhythm on these medications. But nevertheless, I've done both. I've loaded with on normal sinus on atrial fibrillation, sometimes fast, and they convert sometimes and stuff like that. So just keep that in your mind. Let's talk about individual medications. So procainamide, we use it in refractory ventricular tachycardia. You'll never be probably asked about that for what you do, but it can be used for refractory ventricular tachycardia or in the case of atrial fibrillation accessory pathway. Quinidine, we don't use much. Disopyramide, we use it in the case of HOCM. Flecainide, we use in the case of atrial fibrillation, paroxysmal, or even persistent after ablation. You don't have to have a CAD, and you're supposed not to have CAD or decreased ejection fraction. And it can cause dizziness in about 40% of cases. So when patients come to see you and they say, well, we have dizziness, check the medications and make sure they're not on the flecainide. Lidocaine, we use it IV. Mixiltin, we use it for some ventricular tachycardia. It's the PO form of lidocaine. Phenytoin, I've never used it actually for antiarrhythmic medication. Then we're gonna talk about the sotalol, CAD, normal ejection fraction, atrial fibrillation. I rarely use it for ventricular tachycardia because more effective on the atrial tissue is potassium channel blocking effect in higher doses, lower doses, beta blocking effect. So when you're going to start this medication, look at the beta blocking dose. And if you're somebody 100 twice a day, probably it's not a bad idea to cut down to 50 twice a day and start your sotalol. Even sometimes may need to stop the beta blocker completely. The dofetilide, we talk about that, look at kidney function, does not really affect the rate that much, and it can prolong QTC interval, and you have to be careful with drug and drug interaction with this kind of medications, especially sotalol and dofetilide. And then amiodarone is the safest short term, but it has least long-term side effects, so you have to be aware of that. But it's handy, it's wonderful. You can use this freaking medication 2.2 grams a day. So when I do AFib ablations for somebody who has long-lasting persistent AFib, I tell them give them 150, then 150, then 300, then 150. So sometimes I load them with 1 gram actually during procedure itself. They're very safe medication, but you have to be careful about the long-term side effects. And then the dronedarone, we don't use it, but there's a value for this medication. If you do not have congestive heart failure, or if you have congestive heart failure class 1 to 2 and ejection fraction is normal, and you don't have persistent AFib or long-lasting or permanent AFib, and in the case of coronary artery disease, it's safe to use, but you have to be careful about this, permanent AFib, congestive heart failure class 3 to 4, and decreased ejection fraction with the dronedarone. The other medication, so we talk about amiodarone, sotalol, dronedarone. What's the other? Class 4, class 3, potassium channel blocker, sotalol, amiodarone, dofetilide, dronedarone. Okay. There's a medication called abutylide covert. I don't really. I've used it before, like 3, 4, 5 years ago. Trying to impress people in the ICU when I had time. So you use this medication, use it 1 milligram over 10 minutes, and it has really success rate, about 80% converting your patient to normal sinus rhythm. But not all the hospitals carry that, and you have to monitor your patient for about 4 hours after the infusion to make sure there's no, torsades after the medication. But we rarely use this medication nowadays. So more about these medications. So always remember the flecainide, propafenone, CAD, low EF. Always remember dronedarone. We don't like to use this medication much. Always remember that amiodarone is safe. Remember that lidocaine, mexeltin, they don't have any effects on the atrial tissue, so they don't help you with your atrial fibrillation. Always remember that procainamide actually does help in both, but procainamide, yes, I want to mention this as well. Procainamide, I say that sodium channel blockers, they do not affect the QTC interval except procainamide, because the procainamide gets metabolized in the liver to NAPA in acetylprocainamide, and then NAPA is excreted by the kidney. So 50-50 liver and kidney. So accumulation of the NAPA can cause QTC prolongation, and you have to be careful about that. So if you have somebody who's kidney failure and you start the procainamide, you may get QTC interval in this case, even though this patient is on sodium channel blocker. So this is rarely, we had to encounter on the this kind of issue, but just kind of FYI for you to know. That's pretty much what I need to talk about. I think, do you have a question, guys? Because it's really a very broad topic.
What would you use as first line for VTAC?
Amio.
Amio?
Then mexeltin. Yeah, I use Amio. Give them like 150 or 300 milligram IV, and then start amiodarone 400 BID or even 400 TID if they have device. And the load, you have to remember in the case of amiodarone, 8 to 10 grams PO amiodarone to have the load, to have steady state of the medication. So you have to remember that always. So you have to be patient. If your patient is not in good rhythm, you tell them that just take this medication for a few days and until you get 8 to 10 grams PO medication to have a steady state in the liver, because what happened is these medications are going to get stored in the liver and then excreted from the liver. So just keep that in your mind. This is why when whoever works with me in the clinic, I start this medication early on before ablation. So by the time ablation is to be done, so you're going to have at least 8 grams in the system. Any more questions?
I have another one actually. So I mean, I see a ton of people on diltiazem, but I haven't seen anyone on verapamil yet.
Yeah,
Why is
I
that?
mean, you're right. I mean, there's really not much difference. If you look at the vesicular VT, for instance, it has better tendency to respond to verapamil than cardizem. But really, they are very, very similar medications, to be honest. So, I mean, you can use either. There's really no, I think both of them, they are metabolized by the liver. Both of them, they have almost the same drug and drug interactions. So they are the same. You can use either. Remember, these medications, if you have ejection fraction less than 40%, they are contraindicated, and you have to be careful about that. You can use them if you have somebody in the ICU who's septic, and you have to use drips to lower heart rate for a short period of time, but you cannot discharge these patients on diltiazem or verapamil. Any more questions? Okay. All right, guys.
All right, thank you, doctor.
Thank you. Thank you, guys.
Yeah.
Have a good one.
Thank
Bye.
All right. Thanks, everybody. We'll catch up in 2 weeks.
See you later, Nick.
Bye.